Top Med Talk.
All right. Well, hello and welcome to Top Med Talk. We are here at the World Congress of Anesthesiologists, put on by the World Federation of Society of Anesthesiologists. I'm Desiree Chappell. I'm your host, and I'm joined by my former co-editor-in-chief, Monty Mythen. Hi, Monty.
Desiree, it's great to be back on the cams.
It is. It's been a minute.
It's been a while. Yeah. You know, I transitioned to take up a position at Edwards Lifesciences. And as part of that, I had to step down from a number of different positions because of potential conflicts of interest. So one of those was very sadly, I stepped away from being editor-in-chief of Top Med Talk with you, co-editor.
Yeah.
That actually, you know, we just agreed that consensually. Because
let's be honest. You got the pink slip.
There was no absolute requirement to do that, but it just felt right because, you know, being editor-in-chief of materials when we might be discussing Edwards products, we might be discussing other people's products, you know, it's...
Yeah. Well, congratulations to you. Yeah. Mike Grocott has stepped up into your role.
I'm coping. I love my job, though.
Yeah,
you
do. You do. You seem so excited about everything that you're doing and all the projects that you are working on. So
very exciting.
Congratulations.
Exactly, because with this, we're going to discuss some Edwards products.
I was just going to say, so
particular podcast, and Edwards are a major sponsor, so we get that out of the way straight away. So if you don't want to hear about that, leave now.
Yeah.
So
turn the page.
Exactly. Well, one of the big pieces of news is Edwards is so-called spinning out.
Yes.
So they announced at the back end of last year. Edwards Critical Care, the major company Edwards is probably most well known around the world outside of our space as structural heart solutions, heart valves, etc. So that span out about 25 years ago from Baxter, has been very, very successful. Now Critical Care has reached such a size that it's ready to be its own independent company.
Yeah.
So soon there'll be a new name, a new logo, and lots of new exciting products. So we're very excited.
That's like you're graduating, is what I've heard.
Graduating. Sure. We're not being sold off.
Yeah.
Yeah, the kids are leaving the house shoulders back to start a brave new world.
Oh, that's great.
And we're leaving with lots of the money and all the toys.
No, sounds great to me.
So that's good.
Well, on that note, Monty, one of your colleagues and a friend of the Top Men Talk family, always a fave, is here with us today. Thomas Scheeren. Hello, Thomas. How are you?
Hi, Desiree. Hi, Monty. I'm glad to be back.
Yes, and sit on the Top Men Talk sofa with us to chit-chat.
I cannot count the times I've been here, but
it's been a couple times. Thomas,
you're still having me.
Yes, well, of course. So tell us a little bit more about your role, your previous role, and then where you are now.
Yeah, so I've been working as a clinician, mainly a cardiac anesthetist for almost 30 years. And then I did a recent development similar to that, but Monty just told. So I joined Edwards Lifesciences 18 months ago. Very exciting adventure, and with that spin-off that Monty just mentioned, of that graduation project, it's a very exciting development with a lot of potential. There are a lot of products in the pipeline, which I'm not supposed to talk about right now, but this makes us very confident and happy about the future ahead of us. So I'm very excited. Also, a downside, I had to step down from a editor-in-chief position of the Journal of Clinical Monitoring and Computing due to that potential conflict of interest in managing papers dealing with our technology. So similar thing, it was a deliberate thing.
Similar.
But bottom line, it's a very positive development. I'm very happy in my new job.
Well, good, and congratulations to you. So I wanted to first, before we get into some of the topics, introduce our guest new to Top Med Talk, Paul von Beest. Paul, thank you so much for joining us here on Top Med Talk. How are you?
Thank you, Desiree, for having me, and I'm very honored and pleased to be here with Monty and Thomas.
Yeah, of course. Well, for our listeners, why don't you tell us a little bit more about yourself?
Well, I've been in anesthesiology for about 10 years now, and I did in Groningen and in Leeuwarden up north in the Netherlands. I did my training in Groningen, and during that time I did my PhD, and I'm very happy to have my professor right beside me.
History here.
That's the history here, indeed. I was his first PhD candidate.
Oh.
That was all about central venous oxygenation lactate in ICU patients and high-risk surgery. So that was a very interesting time.
Yeah, definitely. Well, it's incredible. Well, Monty, we're going to start off kind of down a road here.
Couple of things we want to discuss very quickly. I mean, one of the things both myself and Thomas have been through in the transition to industry is how suddenly gagged you get
Oh, yeah.
in the world of academic debate. And we've been dealing with...
So it's hard for some more than others.
It's really hard to keep quiet. So for the last, I don't know what it is, 18 months or so, we've been dealing with some excellent questions that were raised about the original validity and development of the hypotension prediction index.
Yes.
Now,
which we've talked about here on Top Med Talk.
Now,
for a bit.
I think very sadly, most of it has played out in social media. Some of it played out in the peer-reviewed journals, you know, from the correction and some extra details about one of the original validation papers, which is all entirely appropriate and proper. But in between, there's been a lot of social media activity, which we quite rightly cannot and will not get involved with, as either as individuals, as academics.
Right.
Is that right, Thomas?
Yeah, that's exactly how it is.
Exactly.
We don't want to engage in that level of discussion.
No, you don't want to get into that space at all and sandbox.
Well, it's not peer reviewed.
Yeah.
So it's not. So we completely welcome and celebrate academic debate. We completely welcome and celebrate the opportunity to discuss that in academic environments and peer reviewed journals. But we're not going to get involved in the social media stuff. So the good news is that the very important question that was raised about how HPI was developed has, I think from our perspective, been explored in very great detail. So there's new publication coming out of over 2,500 patients to re-explore the validity of the hypertension prediction index. That will be seen in abstract form in Brussels
Coming up.
next week, supported by a lot of extremely well-known academics who've been involved in the development of the technology. And I think we welcomed the challenge because it gave us a chance to re-explore it. And also dealing with one of the social media criticisms, which I think fundamentally relates to something called mathematical coupling. We don't need to go into that now. But
Thank you.
I'm old enough to have lived through it the last time that it was a debate related to oxygen kinetics. But anyway, both those abstracts will be out in Brussels, and hopefully the paper will be out very soon that allows a peer-reviewed discussion of the great questions and challenges that were raised. That nothing against people who want to have academic debates. We highly value.
I say you encourage that, right?
Yeah.
I mean,
So we looked at the criticisms, and basically the challenge is that we just fundamentally disagree.
yes.
If you see what I mean, which is the nature of having academic debates. We've listened, we've looked, we've explored it. We fundamentally disagree. If you can convince us that we're wrong, we're happy to go back and look at the debate again. Thomas, you've been a little bit too close to this for reasons that,
One of the criticism worked with me in my lab while we did one of the validation studies. So he took data with him and reanalyzed it and came up with some interesting results, which we are currently looking at, as you said. Of course, there are different ways of statistical approaches to analyze a data set, and we reanalyze the data, as you said, by the different possibilities that there are, and we come to the same conclusions, which is reassuring that the original validation was correct and was good, and we are going to publish that very soon, hopefully, and that's the good news.
And he said, when you have to also say, when we say we, it doesn't mean myself and Tom.
Did any of that?
I'm sweating over a spreadsheet somewhere. We have a large, at Edwards, we have a large, extremely high quality, ex-university academic department that does data and does artificial intelligence. And then you get secondary eyes on that for secondary and tertiary validation of that. And then your clinical academic colleagues who generated the original data join you in the peer-reviewed publication. That's great. There's always a possibility we've still got it wrong somehow. But damn, we've
You have pretty hard to make
really hard at the alternative view, and I'm really sorry. We just think you're wrong. But anyway, please do have a look and join in the debate. And Desiree, you use it clinically. I think as a clinical user, what do you think?
Well, I mean, whenever you start using any new technology, you're going to have lots of questions about it. How does it work? Some things are a little bit of a black box. What does that mean for me? What's it going to mean for my patient? And that's all appropriate. You should ask those questions. Then once you get past, it's safe to use, and this is something that can work in my workflow, and you really start to work with it and learn about the technology. I mean, it has opened so many doors for me as a clinician, and really, I feel like improved the way that I deliver care. And it's because I've embraced it and learned how to use it, and figured out how to adopt the technology into my workflow and how to gain. And this is something that I talk a lot in change adoption when I'm lecturing, is that you have to have time to gain confidence in what you're using and see that it can really make a difference in how you're delivering your care. And hopefully if you see your outcomes, you know that it's making a difference in your outcomes. If not, at least experientially, in the case of HPI, that you actually are truly reducing the amount of hypotension that you're having. And I've had some of the same questions that have been, asked about the literature and been able to actually use it myself and figure it out from kind of figure out myself.
And part of that, which has given us a chance at Edwards to refocus on, is when it alarms,
Yes.
you see what I mean? When it goes red and shouts at you, the HPI's got up to a level of 85.
Mm-hmm.
And by that stage, the blood pressure is probably getting closer to the threshold of 65.
Yes.
Now, that's an alarm that's sort of telling you, if in the car equivalent, which we often talk about,
Yeah, we've talked about
it's
that.
telling you you're about to crash.
Yeah.
So if you are actually concentrating and had your eyes open, you could argue you didn't need HPI or the car that stops automatically.
Yeah,
Because if you were concentrating, you could brake and not crash.
that's right.
So you could say, well, just set the alarm at 70 or 72 or whatever it is, and you're going to get a very similar thing. And there's an argument, yes, that would give you the same lead time.
Yeah.
But that's really not the point of HPI.
No, and I mean, we
point
have a
out-
million alarms.
The point of HPI is way, way back in the journey,
Yes.
that when it was 20 and went to 30 or 30 and went to 40 or got above 50, and that's way ahead
Yes.
of those other changes. And that's the bit that's been lost in translation.
And I mean, it's predictive software. You want to be able to use it to proactively avoid hypotension, not stand on the precipice. And if you wait a couple more minutes, you're going to dump over into it. Sorry.
So his two early
Yeah.
experts have been years working earlier technology.
Yeah. But Paul, what do you think about this?
I really love the technology because what you try to do is try to avoid hypotension or at least hemodynamic instability.
Yeah, right. Is really what we need to be talking about.
But
Yes.
when it starts rising, as you said, Monty, you already can look at the secondary screen. And what you see
That's
is
key.
preload, afterload, and contractility. And that's physiology right there.
Yes. At its
And-
best and being able to see it where you've never been able to see it before.
Absolutely. And every anesthesiologist has been taught what the meaning of that is
Yeah.
and use it and not just turn up the volume of the norepinephrine or something like that, trying to get a better mean arterial pressure. But maybe you should do something else. That's what the machine tells you
So
before it happens.
I'll shut up about this in a second, but so let's imagine you wanted to be a set the alarm person. If you set the alarm at whatever you choose, 72 for example, when the alarm goes off, what do? You look at the secondary screen.
Yeah.
There you go.
Because you've got the whole purpose of it is to inform you about the likely cause of hypertension and treat the underlying cause. If you set the alarm at 72 and you don't look at the secondary screen, there's a real possibility that you're just going to give a vasopressor,
Yeah.
which we're seeing loads of now, which seems to be hurting people, not helping people.
Well, they're treating the hypotension and not what the...
So nothing against setting an alarm if you really don't want to discover HPI, but I would hope that people would look at what's the underlying. Is that fair?
Exactly.
Because we're never going to get around to talking to AFM if we spend all of our time talking about this.
Yes, please.
Thomas, very quickly,
3 letters.
we talked to you back at the European Society of Anesthesia about a paper that was in press. I think it's been published now.
Yeah.
About the difference between education and having decision support in the form of HPI. Very, very quickly, because that paper's out now.
So very quickly, so first, if there's a new technology like HPI out there, you need to validate it. So we did the validation study, which we talked about.
Mhm.
Second thing is you have to prove that the technology does what it's supposed to do. So it has to reduce hypertension. Yes, there are plenty of studies out there. Now, in the third phase, we looked at does it change the behavior of the clinicians that are using it, and does it change to different treatment ways? And what are the barriers of implementing it in clinical practice? So we did that with surveys of healthcare providers in 2 centers in Groningen and in York in the UK, and we found out that barriers were actually low. People were confident that they can reduce hypertension. They have the tools for that. They realized that hypertension is a bad thing, that it's a priority to treat, and they were confident that they could treat it. And they found low barriers of implementing it. And then we looked in 3 phases, in 3 groups of patients, what actually happened. So in the first phase, they were just told, it's a study, and so we're doing a baseline measurement. What is the rate of hypertension and what drugs do they use? Then we told them, okay, this study is about hypotension. We want you to avoid hypertension, so please make sure that blood pressure is always above 65. And these are measures how you can do that. So a structurized education, and guess what? This alone, having a mandated blood pressure target, did not reduce the amount of hypertension. Only when we, in the third phase, gave them the HPI and taught them how to use it and give them the clinical guidance like secondary skin and an algorithm, they were able to significantly reduce HPI. So this is coming back to that, what we just discussed with Paul, just setting an alarm and telling them, please keep blood pressure above a certain level, probably does not help. So it is the HPI that it was actually reducing the hypertension.
Did you look at the compliance for that third phase?
Yes, compliance is, of course, important. It has to be above 80%. It was way above 80%. So yes, we can rely that the data are...
Sorry, can I just interrupt? The compliance with...
No, the protocol.
The second screen.
Yes.
So, of course, people have to follow an advice when it is given. If they don't follow it and don't believe in the technology, then you cannot expect a difference. So yes, we made sure that they understood the structured education that we gave before they were using it, and that they were following it. And so the compliance was high, and this is a requirement for having this out.
So compliance is secondary screen says, I think, because I've set the variables, I think it's what I believe is preload, because I believe in delta stroke volume, for example.
Right.
And compliance is, it said preload, you give a fluid bolus.
Exactly.
It said contractility, you give something to, so that's great. Thank you.
Yeah, that's great. I mean, this is a very, sorry, go ahead.
Speaking about the contractility, this was the dramatic change that we found. So people were not using inotropes because it was not even on the card in the anesthetic room at that time for the non-cardiac surgeries that we're talking about. Now they see what we call the DPDT. It's a measure of the contractility. So they see how the contractility is affected by the anesthetics or by the surgery. And they can treat it causally. So they use a lot more of these inotropes, because if the decreased contractility is the reason for that hemodynamic instability or hypertension, this is the causal treatment.
And by that I mean ephedrine rather than phenylephrine, or that calcium. It doesn't necessarily have to be an epinephrine infusion or a dobutamine infusion. It just means don't give pure alpha, give beta.
Exactly. But these kind of drugs were not available prior to that study. Now this has changed.
Has this been your experience, Paul?
Absolutely. And the good thing was, in the beginning, after a dozen cases or so, we got good feedback, because when we started, as probably everybody says, I don't have hypertension. I can see that.
Yep.
And they showed us, and then, oops, there was quite a lot of hypertension. And we were able, while using HPI, to significantly reduce the time weight average at a time of being under the cutoff point of 65 millimeters of mercury.
Yeah.
So that was wonderful. And so ever since, we've been using it and teaching our anesthetic nurses. We got a super user team that also really works. So with a couple of colleagues, and it's important what Thomas says, if you don't have things like dobutamine on your card, they never use it. So I introduced it while setting up goal-directed therapy in my hospital. Also, in using AFM, another topic, we see that when you use it, there is much more use of inotropes.
So we should switch gears.
I was going to say, I could geek out on this forever, but we need to move on. I know, we may.
Because at Edwards, we have a very, very rich pipeline of artificial intelligence-driven algorithms. And there is a new kid on the block, some people, which is what, Desiree?
It's AFM.
There we go. What's that? Is that what you... There's AM and there's FM in my car radio.
That's right.
What is AM?
So AFM, assisted fluid management. I've seen this, not in practice yet, but I've had my hands on the device and learned a little bit more about it. But Paul, this is something you've actually been working on for a while now, yeah?
Absolutely. We started it in 2018.
Oh, for definitely for a while.
Yeah, so the very first version.
Only 15 years until it's ready to move from market, typically. So well done. They've only been fine. So
there it was. And what we did back then, before the pandemic, we did about 75 cases. And it's a system that is really easy to use. Once you're getting used to goal-directed therapy
Yeah.
with these numbers like stroke volume, cardiac output, etc., then at one point the machine just says, okay, maybe you should give fluid now.
Yeah.
And then you can do it, or either ignore the proposed bolus.
Mm-hmm.
Of course, in clinical setting, sometimes you deny it
Yeah.
because the patient is head up, for instance,
Exactly.
or there's something going on, atrial fibrillation, or when I do lung recruitment,
Yeah.
then the machine sees different things
Yeah.
happening in hemodynamic status.
But you as a clinician know actually what is going
You
on.
know what's going on. You
Yeah.
also have to keep thinking, you know what's
Yeah.
going on. Exactly. And that was lovely. And these patients we compared with an historical group, a mass historical group.
Mm.
And what we did see, because in the beginning you could say, okay, maybe we will give more fluid.
Yeah. That's what I was just going to ask.
But actually, we give less.
Huh.
What we do with maintenance, we give 2 mLs per kilo per hour
Mm-hmm.
maximum. And then AFM comes in, and then we give a fluid bolus. What I do in practical sense is that after induction or just right after induction, I give the first bolus. And after that bolus, the machine starts to learn from the response of the patient.
No.
So that's what's happening. So the machine is learning, and during the case, it will be more and more accurate while we give the fluid boluses.
So embedded within the machine, because we've already got, the trend lines of, let's imagine we choose SVV or stroke volume. This is beyond that, as I understand. This is a form of artificial intelligence.
This is artificial intelligence.
True machine.
And this algorithm consists of 2 parts. First, the static part, and you have the dynamic part. The static part is just the machine. When you start it up, the machine looks at the hemodynamic status of the patient at that time.
Snapshot.
It's a snapshot. You can see it like a sort of landscape.
Mm-hmm.
It forms.
And compares it to the population.
And compares it to the population.
Base values.
Which is in the algorithm itself. And once you give a fluid bolus, the dynamic part of the algorithm comes in play. And the machine is starting to learn from the response of the patient. And once you give about 3 boluses, the prediction, the dynamic part will be 80% of that prediction. And it might say, I've never seen this in hemodynamic status, and then you get a question mark, and you might give a test bolus, or it says, okay, now you have to give a bolus because there's something going on then.
So it sort of identifies the individual Frank-Starling curve of that patient, and the position where patient is at this point. Can we say it like that?
Yeah, you can say it like that. And in remembrance, the Bellamy curve, you don't have to give less fluids, you don't have to give too much fluid.
You're hitting
and that's
the sweet
obvious.
spot
You got
every
a
time.
sweet spot.
That's it.
But that curve
Yep.
is based on the population. There are already 2 very large studies out there who actually show the Bellamy curve exists.
Yeah.
But that's all about big numbers, and you should treat the patient.
Yeah.
And we have to go to personalized medicine.
Mm-hmm.
And when the machine is learning from the patient, once you give him the bolus, then you're treating the patient. For instance, when I'm on the operating theater myself, I'm 40 years old, the anesthesiologist treats me different than my mother, who's 81 years old.
Yes.
And you can imagine that we both have a different reaction on that bolus.
Yeah.
So you have to be on that sweet spot, and AFM gives you that sweet spot.
Yeah.
And there's another thing with it is a new twist is also the fluid meter. So people might say, why do we need a fluid meter?
I was going to ask that.
Well, we've had a long period, it's been well recognized that most volumetric pumps that we have access to are limited to 1 litre per hour of fluid.
Mm-hmm.
If you want to give a fluid bolus in the time period that's recommended to be physiologically relevant, you can't do it with a regular volumetric pump.
Mm-hmm.
So most of us use a gravity-fed rollerball system.
Yep.
Which means that in the world that we live in now, there's no automatic capture of the flow rate or volume that we're giving.
Yeah.
So the fluid meter is an inline fluid meter that talks to the monitor and therefore enables talking to the electronic health record. that says how much fluid has been given through your resuscitation.
Yeah.
That's how I understand it. Thomas, is that about right?
Can I ask, before you answer, does it take like the numbers, and that's like part of the whole algorithm and the learning part, to say, I know you gave 150 cc's and you're going to respond to that next time kind of thing?
Yeah, it's to the past where we just opened up the bag and said, okay, we want to give 250 milliliters. So we gave more or less, but it could be 300 or it could be 200.
Yeah.
Because we're just looking when is the bag half empty. And now it's very precise. And it's also depending on the type of fluids, be it a crystalloid or a colloid fluid, you can tell the system. So it will accurately track the volume that is actually being given. And this is most useful, particularly if you want to analyze the effect of that fluid bolus, the hemodynamic effect. So then you need to correlate it with the actual amount of fluid that is being given.
So, and I love that feature because I'm a bit obsessed about keeping track of your rough estimate of where you are on fluid balance.
Yeah.
Because there's been a sort of loss of confidence of giving enough fluid. There's concern about giving too much fluid. You can now look at your running fluid balance that you're giving through your resuscitation line very reliably and have the confidence to give more and know when it's a time to think about stopping.
Yeah.
As opposed to just working with magic numbers. Is that fair?
Yeah, that's fair. That's fair to say, I guess. Yeah, more precise, and it gives you good feedback right there.
Yeah.
And also, I'd like to add that there was a study done in 2019 by Alexander Joosten from Brussels.
Yeah.
And they also compared it with a historical group of about 40 patients. What was most striking of that study is that they had a very high compliance. So whenever the machine says, bling, give a bolus, in 91% they gave a bolus. And what happened? There were no more complications. There was no more morbidity. So that tells me it is safe to use. We didn't have that high compliance in our study, but it tells me it's safe to use.
Yeah.
You were saying it makes your life of giving fluids easier.
Easier, of course, because there was goal-directed therapy has been out there for years. There are a couple of meta-analyses that tells us, okay, there is less morbidity while using goal-directed therapy, but it is not implemented as it should, despite the fact that it has been incorporated in all these guidelines that out there.
But this new technology advancements, are you not afraid that it will make you as an anesthetist superfluous one day, that you will lose your job because the technique will take over? Because I was attending a session this morning here at the WCA conference talking about closed loop, which is the next step of applying these technologies. So aren't you afraid that these machines will take over your job one day?
Yeah.
Absolutely not. Absolutely not.
Because it's still your brain that is...
It's still my brain that sees what's happening on the other side of the drape. That's one thing. So
yeah,
we always be there.
And that can accept or decline that suggestion to the fluids, right? And that's
absolutely. Yeah. Yeah. And as I said, it is safe to use it, and you can recline it. So yeah.
Well, interesting. What are the other clinicians there that you work with? How do they feel about the technology?
They feel good about the technology and they feel confident with it, and it's relatively easy to use. It takes time, once you have to implement a new technique, whatever it is, it takes time. But as I said, we have a couple of super users. We started with 4, now we have 12 with anything. In the Netherlands, we work with anesthetic nurses. And I started with another colleague, and now we have a team of 5 anesthesiologists.
Oh, great.
Working out there.
Yeah.
And that's working very well, to be honest.
Yeah.
Yeah. They feel confident, they get good feedback.
Yeah.
And they're using it.
Well, it sounds like we are starting this journey. It's been going for a little while for you guys, but a lot of us will be starting this journey and hopefully find out more how to incorporate that into...
And LFM stands for?
Assisted Fluid Management. Thank you so much for joining us. This is a wonderful conversation. I've loved hearing about your experience in this, and congratulations on the work that you're doing.
Well, thank you very much.
Yeah, absolutely. And Thomas, thanks for joining us once again. I'm sure this
Thank you
won't
very much.
be your last.
I can't wait to join the next.
Yeah. And Monty, thanks for joining us here on Top Med Talk.
Great. Well, it's wonderful to be in a position to say how very, very proud Edwards have been to be the original sponsors of Top Med Talk. I hope they keep sponsoring Top Med Talk. I'm certain the new company will. If you see what I mean.
I appreciate it. I'm thinking me. Me thanks me. All right. On that note, thank you so much for listening to Top Med Talk. You know, you can always find us on Twitter, LinkedIn, Facebook. We are there. TopMedTalk.com is where you need to go for everything, except for we now are on YouTube. So if you want to go on YouTube, if you consume some of your streaming content, things like that on YouTube, check out Top Med Talk. If you like us, hit the subscribe button. Give us a thumbs up. We really do appreciate all that. So anyway, thanks everybody for listening. Thanks to our guest. Have a great day. Cheers.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.